Hi everyone, this is Neel Raithatha, consultant audiologist and director of ClearWax. Thank you for joining me in another demonstration video of our soon-to-be launched WAXscope, which has an official launch date of Friday the 12th, 2024. And this case was a really challenging one. It's of a patient who I saw a few years ago, and I was reading my notes prior to the patient entering, and I documented just how narrow and twisty and bendy their ears were, and I thought, well, there's no better time to really to trial out the WAXscope. So I'm just commencing with their left ear, and I'm just starting off using our medium-sized speculi, the 4.25mm speculi, but a bit later on, both in this ear and their right ear, I do revert to the smaller one just to get a bit better access into the ear. So the wax plug here is just situated past the second bend, which is about a centimetre into the ear canal, give or take. And they've got quite a high keratin content in this wax. So earwax is made up of 3 primary ingredients: dead skin cells, sebum, which is an oily lipid secretion from the sebaceous glands that are attached to the hair follicles, so the hairs that you can see. So we all have these hairs. These are normal at the entrance in the outer third of the ear canal. And it's also an amalgamation of emotional sweats secreted by emotional sweat glands in the ear. They're called apocrine glands. And generally earwax, you get different types, different grades, different consistencies, but general Western earwax is probably about 60% made up of dead skin cells. But I would say here it's probably a bit more of a higher content, and we can tell that by the appearance. It's quite glossy and reflective. So keratin is, which is the protein that's found in these dead skin cells, they do reflect a lot of light. So when you get a glossy appearance like this, you know there's got a lot of skin content, and the skin is actually making it quite difficult to remove. You can see the skin here at the base, because it's also, not only is it enveloping the exterior of the wax plug, but it's still attached to the canal wall. So the challenge here is to bring it out of the narrow ear, but also past this very prominent second bend. You can see this tail of skin that I've just removed, and that will help because we're removing some of the adhesions. So I'm just getting that in focus. Now, interestingly, I also started off using, I've got some head loops, and I thought, let me try them in this patient's ear, but I just, maybe because I don't use it as often, but I had to stop, and I just reverted back to the WAXscope here. But I thought this would be a good comparison for me to compare the difference. So now, slowly but surely we're bringing it away, but I think we're going to have a bit of a challenge here because this is more medial wax now, so this is really impacted. It's been about 3 years since this patient attended last, and they've got some water in their ears recently, which further exacerbated their symptoms, and they're literally not able to hear upon attending. So when I was speaking, you can just tell by the patient's reaction that they weren't really confident, even although I was kind of raising my voice. They weren't fully confident in what I was saying, and their phone rang during the procedure. The patient forgot to put it on silent, and it was so loud, the ringtone. And after the procedure, I did explain to the patient they need to turn their ringtone down because it will be deafeningly loud. So again, I'm just trying to separate. I've just put some olive oil, medical grade olive oil spray in here. And again, you just got this skin content. So with the WAXscope, as it is with head loops and an ENT microscope, the further you go into the ear, you need to just adjust the focus. So the depth of focus in comparison to an endoscope is far less, and it's one of the benefits of an endoscope, as well as the field of view, because the lens goes in the ear. But it's almost like if you've got your phone and you're taking an image, you need to focus it onto the object. So that's what we're doing here. And you can see this more medial wax, the deeper wax, is a lot darker, so it's been there for longer, it's oxidized. And again, I'm just trying to separate this really. It's got this consistency, it's almost like a gluey consistency as well, so it's stretchy, which kind of, you're just hoping with this type of wax you get a good suction grip and it all comes out in one plug, but it's not. It's separating and it's stretching as it's coming away. So we're probably now on the last third, the So this is kind of compressed against the eardrum. So on the latter third, and I'm just trying to stretch the ear a bit more, straighten it. I'm just going for the floor of the ear canal. I think I'm just going to adjust the focus there. As you can see, again, some more skin. So most of that skin looks like it's been removed now because you've just got a darker, less reflective lump of wax. And I'm just hovering on top of it. I'm just trying to slowly suction it, because if you embed the suction probe a bit too much, then it can block the suction probe. So I'm just now going to the top. Again, it's very reflective in that area. So there's a few hairs that are matted against this wax, and the idea here is to drag it down. But there's a bit more keratin at the top, so I'm going to have to remove this first, I think. And this is the front part of the ear canal. So I know a lot of people don't like the view of the WAXscope, but this is how, this is the normal view if you're not using an endoscope. In fact, it's an enhanced view. So yeah, it took me a while actually just to get back to using this type of view, because this is the view that I'm used to as an audiologist through my training using an otoscope, and also when I used to use loupes and an ENT microscope. But with the endoscope, you're almost kind of spoilt in a way, because you just get a fantastic view. And you can probably see there how narrow this patient and how twisty the ear canal is. So again, I'm just further inserting the specular, just trying to dilate the entrance. And it's one of these procedures, you just have to be quite patient, really. And it's really funny. I had a really odd email the other day, and I had to share it with my ENT colleague. It was just someone who emailed, and they said they've done 30,000 wax removals and they can do it in 2 minutes, and it was really peculiar. A bit of an odd email, it's out of the blue, and I just thought, I'm not going to get you don't want to really get involved with this as well. Best of wishes. And it was because they said, oh, they can do the wax already, they don't need the WAXscope. Well, no one really, you're on our mailing list, so hence why you got the mail. It's very peculiar. So again, just slowly bring that out, and you can see how we navigate into the ear. So it's left to right, into the ear, then stretching it. And this, again, summarises the difficulties with earwax removal. So one of the things I want to stress is that the WAXscope is not designed to make earwax removal easy, because earwax removal is not easy. It's very, very challenging. It can be very, very difficult, but it's designed to make it easier. And that's really important to recognise. Even with the endoscope, I often find some cases really complex, and certainly couldn't do it in 2 minutes. My ENT colleague actually said, well, we should invite the individual to run a training course for us, and obviously show us what we're doing wrong, if we can do it in 2 minutes, every procedure. So again, the bottom right is just a bit of an opening now where some sound can get through to the patient's eardrum, and they did say they could hear a lot better already. And I'm just going to come back out. Again, just going to enter the ear, straighten it up, adjust the focus, as you can see. And I was quite happy because it was one of the more challenging cases, and obviously I want to make sure the WAXscope is not just for your simple cases. I wanted to make sure it's suitable for really complex cases, and I would classify this as more of a complex case. And just slowly, almost rolling it forwards. You can see little kind of movements with the suction probe, and now we're kind of starting to tease it out. So this patient was just asking if there's anything they can do to stop the build-up, and just explain there's more don'ts than do's. Don't get water in the ears. If you've been watching my videos for a number of years, you know I'm strongly against water getting to the ear, because it can get waterlogged, it can lead to an infection. And don't poke in the ears. And unfortunately, this patient's ear anatomy is just very lending to a wax buildup, because in most people, wax migrates out of the ear. So our ears are self-cleansing. There's a layer of skin lining the ear canal and eardrum, and that skin, as it reproduces, it sheds itself, so that old skin naturally moves sideways out of the ear like a conveyor belt. And as it does, any wax sitting on the surface is naturally transported out of the ear. But in this patient's ear, as the wax is being migrated to the second bend, where it's very twisty, it's just getting trapped. So the blockage is gone. It's just going to get some of this out. I don't get all of it out. And I think with an endoscope, you'll just get a better view to remove this off the set of the canal. So I'm just hovering through, just using a fine end. So again, with an ENT microscope, head loops, or even the WAXscope, there's some parts, you just, again, like the anterior recess, which in this patient's ear, the left ear would be on the left-hand side near the eardrum. It's sometimes very, very difficult to visualize it. And in some cases, you just wouldn't visualize it in the absence of an endoscope. So again, it's just surface wax. We're going to be careful on the bony part here. So I'm not too concerned. I think I'm just going to remove a little bit more. So this is when I just reverted to the smaller specular size. So we're going in, stretching the ear. There's just a bit of skin there. I'm just going to get that in focus. I can peel that away and then just mop a bit more up. And then we're going to move on to the patient's right ear. You're just going to be careful with clarinetting. So when you suction dead skin, quite often the skin violently flaps at the end of the suction probe, and that can emit a very loud, high-frequency squeal. So this we weren't getting any clarinetting here, so that was good. So again, just hovering over some of the surface wax, and I'm kind of happy with that. One of the things that you'll probably see me more now do is just leave a bit more wax in the ear if necessary. So it's the more and more research I did, so just going to have a look at the eardrum. So you can see it's quite stained. Now this patient did use a lot of drops, so what had happened is as the wax got really soft, and it was on the drum, it settled on the drum, it became quite, it stained the drum. But yeah, I was doing the development of the nuclear wax training material, just read so many more journals and research, and there's still a lot more research I think that needs to be conducted about microsuction in particular, and about the noise levels. And the literature is all stating that the general consensus is that yes, it's noisy, and it is noisy. I've experienced it myself, and when we train our clear wax specialists, we always want them to experience it themselves. I think it's really, really important. If you're performing a procedure on a patient, you need to kind of understand what they're experiencing. And that actually, one of the studies that highlighted that, they said it's really important that clinicians appreciate the noise generated by microsuction themselves, so they can have an appreciation when patients report it back. But yeah, the general consensus is that it is noisy, and patients need to be made aware of that. But the noise levels don't lead to any long-term problems. Of course, if you're exposed to any type of noise for a period of time, there's a risk of causing a temporary threshold shift. So that's when you're hearing, my younger days, when you go out to nightclubs and it's really noisy, you get a bit of tinnitus afterwards, and your hearing may not be as good. So any sounds above 85 decibels, you have then physical changes to the outer hair cells. So within the organ of hearing itself, the cochlea, we have inner ear fluid, and we've got tens of thousands of hair cells. And these hair cells, hard to describe, but at the top of them, they have what we call stereocilia. It's almost like, how would you best describe it? It's almost like a strand of hair on top of it. And in response to loud sounds above 85 decibels, thereabouts, these hair cells in response to sounds, generally they shear side to side, and when they do, they produce an electrochemical response, and that is then transported to the brain via the hearing nerve when we process that as sound. But at very loud high levels, those stereocilia, those little kind of wires, if you like, on top of the hair cells, they kind of can contort and shear out of place, and the hair cell itself can also go through physical changes. And because the cell is there's a lot of chemical activity being occurred within the hair cell. You get a buildup of what we call free radicals. So free radicals, they are highly reactive atoms, molecules, and going back to chemistry days, they're missing an electron in the outer shell. So for that reason, they're very reactive. They want to complete their outer shell of electrons, so they can start then being reactive with other cell tissue. And if you have an abundance of free radicals, not only in the ear but other parts of the body, it can lead to the necrosis, the death and decay of hair cells. So that's what can happen in response to very loud sounds. You have physical changes, contortions of the hair cells and the stereocilia, and you have a buildup of free radicals which can lead to cell death. So your ear needs a period of recovery. So that's why after being exposed to loud sounds, like a nightclub, busy bar, your hearing may be a bit down for a period of time, and you may have a bit of tinnitus, a bit of ringing or buzzing noise, and then it gradually improves over the course of about 48 hours. So yeah, when you do microsearching, because it is quite noisy, some patients can experience that. But obviously, when you've got a lot of wax like this, the wax itself it's blocking the ear. So if it's unblocked ear in particular, so there's not any wax and you've got a suction probe, it can be quite noisy. So yeah, part of the clear wax development of the new literature and training modules, I've just learned so much more. So it's kind of changed my practice a lot more. I'm going to feel a lot more confident now just to leave a bit more wax in. It's not going to cause a problem. So again, very bendy, twisty ear. So you can see the second bend on the right hand side there. So we're kind of trying to, it's almost in degrees. Let's estimate what that would be. It'll probably be I wouldn't say 90 degrees, but not far off, probably 70, 80 degree bend. So you go into the ear and then the canal veers off to the right here. And it would be kind of ideal if this wax is a bit firmer, because you'll get a suction grip and it will just come out in a plug, but it's just got this really type 6 consistency. As a bit of fun, I developed the kind of a modified Bristol stool chart for earwax. And so you have your type 1 wax, which is really, really dry and rock solid hard, loads of keratin. And then you have your type 6, which is really mushy and loose and wet. So on that scale, this would probably be a type, probably a type 5 or type 6 maybe. So again, just going to adjust the focus. So if I was using loops to adjust the focus, I would just have to go closer, physically closer with my head into the patient's ear. And with the microscope, what you do, you've got kind of a pair of binoculars really on a stand, and there's like a handle on the binocular, on the unit where the binoculars are, and you would have to physically, with one hand, grab onto the handle, and then in this case you would move the binoculars closer into the patient's ear to regain focus. With the WAXscope, it's slightly different. You just slide it on the app, on the home screen. There's a little slider just with your finger, and you can double click as well. You can double check. It's worked pretty well, the autofocus. I wasn't sure how effective it would be, and I wouldn't say it's 100% accurate, but we're probably talking the high 80s, 90s. So it's pretty good. So we've removed the majority of the wax. Just gonna now the rest of it slowly coming away. What I perhaps should have done, and I might I'll try and remember to do in the other videos, is at certain stages going with the endoscope, so it gives you kind of a better idea of the anatomy of the ear and the architecture of the ear. So this is now on the patient's eardrum. You can see the eardrum, the blue tinge just appearing. So we're now taking this directly off the drum. And I'm using the smaller specular just to get access into the ear, because it just wouldn't be possible to get access with the bigger speculum. And we just dragged that forward, so we brought it to the second bend. We're going to just straighten the ear canal, going to get it in focus. As you can see, it's very quick and easy to get it in focus. And slowly bring it, it's just got lodged there beyond the second bend. So if you are a clinical ear care specialist, removing earwax or wanting to remove earwax, if you're a suitably qualified clinician and you're interested in the WAXscope, please do feel free to contact us on info@clearwax.co.uk. We can give you some more information. We're nearly there now. So I'm just struggling to get the suction grip here, so I'm just hovering, because I feel as though when I'm making contact, it's going the opposite. I'm pushing the wax in. So I've just got to hover, and there we are. And I've got a better suction grip. And now I'm just going to manipulate it out of the ear. And then I'm just going to go all the way to the left and then back to the right. I'm just going to get the eardrum in focus. You can see that there's a little hair strand on the eardrum. I'm just going to mop this bit of keratin out of the way just to get a bit of a better view of the eardrum. So back in, I'm going to stretch straight in the ear. I'm going to just see that bit of a hair strand on the eardrum. I'm going to leave it. You can see the blood capillary there. You can see a really clear view of the eardrum and the handle of malleus. And that's all complete. So thank you for watching, guys. Take care, keep well, and speak soon. Bye.